Welcome to the Deep Dive, the place where we turn massive amounts of dense clinical data into absolute mastery.
Yeah.
Today, we are undertaking a really intense deep dive into the world of medical lasers. This is a technology that truly bridges, the abstract elegance of quantum mechanics with the ultra precision needed right there in the operating
Oh,
theater.
absolutely. It's arguably one of the most critical technologies in modern medicine. I mean, just consider its scope. Here's a device that evolved from, well, a mid-century scientific curiosity based on Max Planck's sort of obscure energy concepts, into the Class 4 tool that's now the preferred scalpel in everything from retinal microsurgery to, high-volume cosmetic procedures. We're talking
Yeah.
about immense focused power.
And that focused power, it demands focused knowledge. Our mission today isn't just about basic familiarity with lasers. No, we are aiming for complete mastery. Mastery of the core physics, the honestly dizzying array of surgical applications, and most critically, the elite safety protocols that professionals must adhere to. Our source material is drawn directly from clinical expertise. It demands a detailed understanding of quantum energy, precise tissue interaction, and those non-negotiable, life-saving safety measures. We're really preparing you to think like the operating room professional who has to manage this complex tech every day.
Because when you're dealing with a beam of light that can be amplified, 100,000 times by the human eye? Well, the difference between an effective procedure and a catastrophic sentinel event is defined entirely by mastering these specifics. It's that critical.
Okay, let's unpack this, starting right at the foundation, the early 1900s. Scientists were grappling with how energy actually behaves, and it all seems to hinge on the revolutionary work of Max Planck and Albert Einstein.
It really does. It truly begins with Planck around 1900. He was studying black body radiation, why heated objects glow certain colors, and he made this profound discovery that energy isn't continuous like a ramp. It's actually transmitted, emitted, and absorbed in discrete, tiny packets. He called these packets quanta. And the relationship he found between energy and frequency became known as Planck's constant. That was like the first seismic shift in physics.
So the universe isn't smooth at the bottom level. It's choppy. It operates in these countable, discrete energy blocks.
Exactly. Then Einstein comes into the picture in 1905, and he defines those specific quantum particles as photons. He kind of visualized the atom as having electrons in specific orbital shells. If you add energy, those electrons jump from their lowest, most stable state, the ground energy state, $E up, to higher unstable energy levels.
And naturally, things want to be stable, so those excited electrons want to drop back down.
Right. Nature always seeks the lowest energy state. So when they fall back down naturally on their own time, they release that stored energy. And how do they release it? As a photon. This natural, spontaneous process is why things glow, like a fluorescent light bulb. Random photons going everywhere.
But that randomness isn't a laser. The real quantum leap, the thing that actually led to the laser, came later. Einstein again, right, with a stimulated emission.
Stimulated emission, yes. This isn't random decay. This is, guided decay. Deliberate.
How does that work?
Okay, imagine you have an atom already sitting in that excited, unstable state. It's ready to fall back down, but it hasn't yet. Now, if a photon comes along, and this is key, a photon with the exact energy difference between that excited state and the ground state, if that photon collides with the excited atom, it forces or stimulates the atom to decay right then and there. It doesn't wait.
Okay, so the passing photon triggers the release.
Yeah.
And here's the magic part, right? The amplification.
This is where the amplification happens. Perfect replication. That single collision doesn't just result in the original photon continuing on its way. No, it also causes the emission of a secondary photon from the atom that's decaying. And the secondary photon is an exact perfect copy.
A perfect copy?
Perfect. It possesses the precise same frequency, the same phase, meaning its waves are perfectly aligned, and it travels in the exact same direction as the photon that stimulated it.
Wow. It's like hitting one domino that makes two identical dominoes fall perfectly in sync.
Exactly. You've suddenly doubled your light output with perfectly matched photons. And those two photons can then go on to strike two more excited atoms,
It's doubling again.
causing 4 identical photons, then 8, 16. It's a cascading chain reaction of perfectly synchronized identical light. And that process is, quite literally, light amplification by stimulated emission of radiation. Laser.
Gordon Gould coined that acronym in '59. Amazing.
It is.
And it's incredible how quickly the hardware followed the theory once stimulated emission was understood.
Yeah.
Theodore Maiman builds the first working laser in 1960. helium-neon mixture.
Mm-hmm.
And then boom, within just 3 years, we're seeing medical applications.
The expansion was phenomenal because the advantages were just so clear, so immediate. The first functioning medical laser was the ruby laser in 1963, but others were right there too. The NAG, which we'll talk a lot about, was developed in 61, Argon in 62, and the CO2 laser, a real workhorse, in 1964.
And that very first clinical use was retinal surgery. Why ophthalmology? Why was the laser so immediately useful there?
Precision. Unparalleled precision. We're talking about the ability to make incisions as small as 0.5 microns, half a micrometer. Think about what surgeons had before. Electrocautery, tiny scalpels, tools that always cause some degree of collateral damage, some burning or tearing nearby.
Right. Not ideal for the delicate retina.
Not at all. Lasers offered superior precision in destroying only the target tissue. They improved access to tiny, delicate sites, and maybe most importantly, they provided controlled hemostasis.
Hemostasis, stopping bleeding.
Exactly. The laser cauterizes as it cuts. It seals tiny blood vessels immediately. In highly vascular areas like the retina, that is invaluable. Less bleeding means better visibility and faster healing.
That level of precision, it completely revolutionized entire fields. You mentioned the excimer laser came along in the 80s.
Yes, the excimer laser. It works differently, more of a photochemical effect, breaking molecular bonds rather than just using heat.
And that enabled LASIK surgery.
Correct, LASIK eye surgery, which is now one of the most common surgical procedures performed in the entire United States.
Incredible. From a theoretical physics concept in the early 1900s to a standardized, life-changing tool in, less than 3 decades?
Yeah.
That's rapid progress.
It really is. But that speed also underscores why understanding the underlying physics and the safety is so vital. The power scaled up incredibly fast.
Okay, so to use these tools effectively, safely, you absolutely have to understand the nature of the light they produce. Let's dive into that, the electromagnetic spectrum.
Right, the EM spectrum, we know it's basically energy traveling in waves. Radio waves, microwaves, infrared, visible light, ultraviolet, X-rays, gamma rays, the whole range.
And the key relationship here, the thing we have to grasp for lasers.
It's the inverse relationship. This dictates everything: safety, tissue interaction, surgical choice. As you move across the spectrum from radio waves towards gamma rays, the wavelengths get shorter and shorter. But as the wavelength decreases, the frequency, how many waves pass a point per second, increases. And critically, the energy carried by each photon increases dramatically.
So short waves equal high frequency equal high energy. Long waves equal low frequency equal low energy.
Precisely. High-frequency, short-wavelength waves like UV or X-rays carry extremely intense energy per photon. Long, low-frequency waves like radio or infrared carry much less energy per photon.
And the formula that nails this down is WAVE equals hc lambda. E is energy, h is Planck's constant, c is the speed of light, and lambda is the wavelength. This isn't just abstract physics, it's the blueprint for surgical risk, right? If a surgeon chooses a laser with a shorter wavelength, a smaller lambda,
then inevitably E goes up. They are choosing a tool with higher energy per photon.
which explains why different lasers do such different things to tissue.
Exactly. It's why a CO2 laser, which has a very long wavelength, 10,600 nanometers, interacts very superficially. It dumps its energy as heat almost instantly in the first layer of cells it hits. Whereas an excimer laser, way down in the ultraviolet with a short wavelength, maybe 193 nanometers, well, it carries so much energy per photon that it doesn't just heat the tissue, it actually breaks the molecular bonds apart. It's a photochemical effect.
Different mechanisms entirely based on that wavelength energy relationship.
Correct. And in the OR, we're mostly focused on what's called the optical portion of the spectrum, roughly from 200 nanometers up to about 1,000 nanometers.
And that includes?
That includes the invisible infrared, or IR, which we perceive as heat. Then there's that narrow little band of visible light from violet around 400 nanometers to red around 700 nanometers. And then there's the invisible ultraviolet, or UV, below violet. UV is known more for causing chemical reactions like sunburn rather than intense heat perception.
Okay, so let's circle back to the atomic level for a second.
Right.
Solidify that difference between spontaneous and stimulated emission. Because stimulated emission is the laser.
Right. Spontaneous emission, that's the default. An electron gets excited, jumps to a higher orbital, then whenever it feels like it, basically it decays naturally back to the ground state. When it does, it spits out a photon. But these photons come out at random times and random directions with a mix of wavelengths and frequencies depending on the material.
So the light is non-coherent. It disperses quickly, energy scattered all over the place, like a crowd leaving a concert just wandering off.
Good analogy. Now, stimulated emission, this is engineered, highly engineered. You have that excited atom, remember? Waiting. Along comes a photon with the exact right energy. It hits the excited atom, stimulates it, forces it to decay now, and out comes that second identical photon.
Identical in every way.
Every way. Wavelength, phase, direction. This cascade, this amplification, creates a burst of perfectly coherent radiation. It's not a scattered grout, it's a highly trained military unit marching in perfect formation, lockstep.
And that lockstep mechanism creates what you call the triad of laser light, the three properties that make it so different, so powerful.
Yes, the three defining characteristics. First, coherence. This is that synchronized motion we talked about. All the photons have the same wavelength, and crucially, they oscillate synchronously in identical phase. Peaks match peaks, troughs match troughs.
They work together.
Perfectly together. That's what allows them to travel great distances and maintain their focused power.
Second property.
Monochromaticity. Mono meaning one, chroma meaning color. Laser light is composed of essentially a single specific wavelength, a single color, even if it's invisible, IR, or UV. A CO2 laser only puts out 10,600 nanometer light. An argon laser may be 488 or 514 nanometers. Now, some modern lasers are tunable. You can adjust the wavelength, but they still only emit one discrete wavelength at any given time.
And that specific wavelength is chosen to interact with a specific target in the tissue, a chromophore.
Precisely. Monochromaticity allows for that selectivity. And the third property, the one that really defines its power application, is directionality, also called collimation.
Meaning it travels straight.
Extremely straight. The beam moves in a parallel, narrow column over very long distances with minimal dispersion, minimal spreading out. Ordinary light spreads out immediately. Laser light stays tight. That's the property that allows surgeons to focus the beam down to that incredibly tiny spot size, like 0.5 microns, concentrating all the energy.
Isn't the famous example of collimation using lasers to measure the distance to the moon?
That's the one. You bounce a laser beam off reflectors left by the Apollo missions. To do that, the beam has to travel hundreds of thousands of miles, hit a small target, reflect, travel all the way back and still be detectable. That requires incredible directionality.
And that directionality, that lack of spread, leads directly to the intensity issue.
Yes. The critical concept of intensity contrast. Look, a typical laser pointer or even a diode in a surgical laser might only emit a few milliwatts of total power. That's way less than even a small incandescent light bulb.
What?
But because that tiny amount of power is perfectly collimated, perfectly directional, its intensity, the power per unit area on the target is absolutely staggering. A 1 milliwatt collimated laser beam can be something like 1,000,000 times more concentrated, more intense, than the light from a 100-watt incandescent bulb spreading out in all directions, measured at the same distance.
1,000,000 times.
That immense focused intensity is what makes surgical lasers both incredibly precise cutting tools and profoundly dangerous if mishandled. That concentration is key.
Okay. We've got the quantum theory, the properties of the light. Now, how do you actually build a machine, a physical device, that harnesses stimulated emission and makes a useful surgical tool? Let's talk components.
Right. Every laser unit fundamentally has three essential components. First, you need an external energy source. This is often called the pump.
Its job is just to provide the power.
Its entire job is to pump energy into the laser medium, to push those electrons up into the higher unstable energy state, creating the excited atoms needed for stimulated emission.
How does it do that?
Various ways. It could be powerful flash lamps, like in some solid-state lasers. It could be a high-voltage electrical current passed through a gas, which is common for gas lasers like CO2 or argon. Or sometimes you even use another laser to pump the main laser medium.
Okay, pump source, component number 2.
The laser medium itself. This is the active material. This is the heart of the machine, the stuff that actually emits the light when stimulated. And crucially, the choice of medium dictates the specific monochromatic wavelength the laser will produce. The medium is the message in terms of wavelength.
And these mediums can be different states of matter.
All sorts. They can be solid, like the synthetic crystal rod used in an ND.YAG laser. That's typically a yttrium aluminum garnet crystal doped with a tiny amount of neodymium impurity. They can be a gas, or usually a mixture of gases, like in argon lasers or CO2 lasers. They can even be liquid, complex organic dyes dissolved in solvents like methanol. These dye lasers are interesting because they're highly tunable. You can adjust the wavelength over a pretty wide range. Or, increasingly common, they can be semiconductors. Little ships, usually gallium arsenide. These are used in small, efficient diode lasers like in pointers or CD players, but also in some powerful surgical systems.
Pump, medium. What's the third essential piece?
The third piece is the structure that makes the amplification happen efficiently. The optical resonating cavity, or optical resonator.
So this is the tube.
Essentially, yes, it's the chamber or tube that contains the laser medium. And at each end of this cavity, you have two precisely aligned mirrors facing each other.
Okay, what's happening inside this mirrored tube?
So the pump is pouring energy into the medium, exciting the atoms. Now, for the laser to work, you have to achieve a specific condition called population inversion.
Population inversion. Sounds important.
It's critical. It means you have managed to get more atoms into that higher, unstable, excited state than are left resting in the stable ground state. It's an unnatural, inverted state for the population of atoms.
Why do you need that?
Because if you don't have more excited atoms ready to be stimulated than ground state atoms ready to absorb, any photon produced is more likely to be absorbed than to cause stimulation. You need a reservoir of unstable energy ready to amplify.
Okay, so the pump creates population inversion in the medium inside the cavity. Then what?
Then, eventually, one excited atom decays spontaneously. It releases a photon. If that photon happens to travel along the axis of the cavity, it hits one of the mirrors.
It bounces back.
Bounces back, straight through the medium again. As it travels, it passes other excited atoms, stimulating them to emit their identical photons. Now you have more photons bouncing off the other mirror.
Back and forth, back and forth.
Exactly. The mirrors reflect the photons back and forth through the medium millions of times per second. With every pass, the light beam picks up more identical photons through stimulated emission, building up intensity and coherence. It's a light amplification feedback loop happening at, well, the speed of light.
But how does the beam get out to be used?
Clever design. One of the mirrors is made to be 100% reflective, but the other mirror, the output mirror, is designed to be partially transparent. Maybe it reflects 99% of the light but lets 1% pass through. So as the beam inside the cavity builds up to maximum intensity and coherence, a small, perfectly formed, perfectly collimated fraction of that incredibly intense internal beam leaks out through that partially transparent mirror.
And that is the laser beam we use.
That is the laser beam, the useful output.
Okay, we have the components. Now, how the laser affects tissue seems to depend heavily on how that energy is delivered, the mode of operation.
Absolutely. The mode determines the thermal or mechanical effect. We generally talk about three primary modes. The workhorse for many bulk procedures is the continuous wave mode, or CW. Just like it sounds, it delivers a steady, uninterrupted beam of power. We measure this output in watts, W.
And what's CW used for?
Things like making a sharp incision with a focused CO2 laser where you need constant cutting power. Or, if you defocus the beam, you can use a CW ND.YAG laser for wide area coagulation, like shrinking a tumor. In CW mode, the key metric is often power density, or irradiance watts per square centimeter, WCMO. How concentrated is that continuous power?
Okay, continuous. What's next?
Then you have pulsed wave mode. Instead of a steady stream, the energy is delivered in individual timed bursts or pulses. These pulses can be incredibly short, down to femtoseconds, or last up to seconds.
And the output is measured differently.
Yeah, for pulse lasers, we usually talk about the energy per pulse measured in joules. This mode is really important when you need to control heat buildup to allow the tissue time to cool between pulses. We'll get into why that's crucial with thermal relaxation time. Think hair removal, often done with pulsed ND-KAG.
Okay, continuous, pulsed. And the third one sounds intense. Q switched.
Q switching is a very clever technique to get extremely high peak power.
Yeah.
It's an engineering trick. You actually put a shutter, mechanical or electro-optical, inside the resonating cavity between the medium and one of the mirrors.
A shutter. Why block the cavity?
You block it temporarily to prevent lasing from starting, even while the pump is still pouring energy into the medium. This allows the population inversion to build up to an absolutely enormous level far beyond what you'd normally get. You're storing up a huge amount of potential energy.
Like holding back a dam.
Exactly. Then, when the population inversion is maximized, you instantly open the shutter, you switch the Q of the cavity. All that stored energy is released in a single, gigantic, ultra-short pulse. We're talking pulse durations of maybe 10 to 250 nanoseconds, billionths of a second. But the peak power released during that tiny instant can be enormous, measured in megawatts, MW, millions of watts.
Wow. What's that used for?
That massive rapid energy deposition doesn't really cause a thermal effect. It causes a photomechanical shockwave. It literally blasts things apart on a microscopic level. Classic use is tattoo removal, breaking up ink particles, often with a Q-switched ND-YAG or ruby laser. Also used for breaking up kidney stones.
Okay, modes determine the effect. Last piece of the puzzle is getting the beam from the machine to the patient. delivery systems.
Right, and this depends entirely on the wavelength. For visible light lasers like Argon and near-infrared lasers like NDYAG, we're fortunate. Their wavelengths travel well through glass, so we can use highly flexible fiber optic cables. These are thin fibers of pure glass or quartz that transmit the light very efficiently. This gives the surgeon excellent maneuverability. They can snake the fiber through endoscopes, etc.
But you mentioned the CO2 laser earlier, the workhorse at 10,600 nanometers. That's far infrared. Does that go through glass fiber?
It does not. That's the big limitation of CO2. Glass and quartz actually absorb 10,600 millimeter light very strongly. If you tried to send a CO2 beam down a standard fiber optic cable, you just melt the cable. Useless.
So how do you deliver a CO2 beam?
It requires a much clumsier solution, an articulated arm. This is basically a series of hollow, rigid metal tubes connected by joints that contain carefully aligned mirrors or prisms inside. The beam bounces off these mirrors at each joint to navigate its way from the laser unit to the handpiece. It works, but it's bulky, it's not very flexible, and it significantly restricts the surgeon's range of motion compared to a fiber.
A necessary evil for that specific wavelength.
Pretty much. And finally, you also have specialized contact probes. Sometimes, instead of delivering the free beam, you attach a special tip, often made of synthetic sapphire, to the end of a fiber optic bundle. This tip absorbs the laser light coming down the fiber and gets very hot right at the point of contact. So it cuts or coagulates by direct thermal conduction like a tiny, precise hot knife, rather than by the light beam itself hitting the tissue.
And that offers different properties.
Yeah, it can give very precise cutting, sometimes with less deep penetration than a scattered free beam because the heat is concentrated right at the tip. Useful for certain sculpting tasks.
All right. Physics, components, delivery. Now let's get to the core. What happens when that laser beam actually hits biological tissue? We're moving from physics into biology now.
We are, and the entire interaction boils down to absorption and heat transfer, primarily.
And the first rule you said is absorption is key.
Absolutely. Rule number 1 for any laser therapy, absorption is mandatory for effectiveness. If the light just passes straight through the tissue, that's transmission, or bounces off the surface reflection, or scatters widely inside without being absorbed, well, then it doesn't do anything useful. It's wasted energy. Or, worse, it could hit something else unintentionally.
So what determines whether the tissue absorbs the light?
It's the chromophores. These are the specific molecules within the tissue that are capable of absorbing light energy at particular wavelengths. In biological tissues, which are mostly water, the 3 main chromophores we target surgically are water itself, hemoglobin, the red pigment in blood, and melanin, the dark pigment in skin, hair, and moles.
So the surgeon chooses a laser wavelength specifically because they know that wavelength will be strongly absorbed by one of those targets.
Precisely. If you want to target blood vessels, you choose a wavelength strongly absorbed by hemoglobin, like Argon or KTP. If you want to target pigmented lesions, you might use a ruby laser absorbed by melanin. If you want to vaporize tissue generally, you use CO2 because it's absorbed universally by the water in all cells. It's tactical.
Okay, so the light gets absorbed by the target chromophore. What happens then?
Simple physics. Light energy converts to heat energy very rapidly. What happens next depends on how much heat, how quickly. If you heat the tissue intensely, reaching 100 degrees Celsius, the water inside the cells instantly flashes to steam. This causes a microscopic explosion, ablation, or vaporization. The tissue is literally blown apart.
Which is how laser cutting works.
Right. It's a very precise way to make an incision. And a key benefit is that the intense heat also seals small blood vessels as it cuts, providing immediate hemostasis. Now, if you use lower power and deliver the energy more slowly, you get heating but below the boiling point, maybe 60, 70 degrees Celsius. This doesn't vaporize tissue, but it denatures proteins, causing coagulation. The tissue shrinks, fuses, vessels thrombose, useful for stopping bleeding from larger vessels or shrinking tissue masses.
So vaporization cuts, coagulation seals, and shrinks. But there's a risk of damaging tissue you didn't want to hit, right? Collateral damage.
Yes. The single most critical concept governing precision and safety here is the thermal relaxation time, or TRT.
TRT, what is that exactly?
TRT is the amount of time it takes for 50% of the heat absorbed by the target tissue volume to dissipate, to conduct away into the surrounding, cooler, non-targeted tissue. Every tissue has a characteristic TRT.
Okay, so it's how quickly the target cools off naturally. Why is that so important?
Because if your laser exposure time, the time the beam is actually hitting the target, is longer than the TRT of that that target tissue.
The heat doesn't stay put.
Exactly. The heat builds up faster than it can dissipate, and it starts spreading laterally outwards into the adjacent healthy tissue. This causes unwanted thermal injury, necrosis, collateral tissue damage. You burn more than you intended.
So to be precise, you need to keep the exposure time shorter than the TRT.
Precisely. This is the entire rationale behind using pulsed lasers for many delicate procedures. By using a pulse duration that's significantly shorter than the tissue's TRT, you can deposit enough energy to destroy the target, like a pigmented spot or a hair follicle, but the pulse ends before the heat has time to conduct away and damage the surrounding normal cells. You can find the thermal effect right where you want it.
Makes sense. Short, sharp, shocks energy tailored to the tissue's cooling time.
That's the ideal, yes. Selective photothermolysis, it's called.
Now, heat isn't the only way lasers interact with tissue, right? You mentioned 4 primary interactions.
Correct. The most common, as we've discussed, is photothermal. Low power, longer pulses, or CW, creating that rapid temperature rise leading to vaporization and coagulation. Most standard surgical cutting and coagulation falls here.
Then there was the Q-switched effect.
Yes, photomechanical. This uses those incredibly powerful ultra-short pulses from Q-switched lasers. The energy deposits so fast it doesn't have time to dissipate as heat. Instead, it generates intense pressure and acoustic shock waves that cause explosive mechanical disruption. Think tattoo removal, breaking ink particles, or lithotripsy, fragmenting kidney stones.
Okay. Thermal, mechanical, what else?
Third is photochemical. This typically uses lower power but sometimes longer exposure durations. Instead of relying on heat or shock waves, the laser light directly triggers chemical reactions. It might break specific molecular bonds or biochemically excite certain cellular molecules to change their function. The excimer laser used in LASIK works primarily this way, ablating corneal tissue bond by bond.
And the fourth one sounds quite sophisticated. Photodynamic reaction, PDT.
PDT is very elegant. It's a 2-stage cancer treatment primarily. First, the patient is given a special photosensitizing drug. This drug is designed to be selectively absorbed and retained by abnormal or cancerous cells, much more so than by healthy cells.
So the drug concentrates in the tumor.
Exactly. Then, after a specific time allows for this concentration, the target area is illuminated with laser light of a very specific wavelength, the wavelength that activates that particular drug. The laser light itself isn't doing the damage, it's acting as a trigger. When the light activates the photosensitizer drug within the cancer cells, the drug undergoes a chemical reaction that produces a highly toxic form of oxygen called singlet oxygen.
And that toxic oxygen kills the cells.
It kills the cells that have absorbed the drug, meaning primarily the cancer cells, while largely sparing the nearby normal tissue that didn't take up much drug. It's a very targeted cytotoxic effect.
Where's PDT used?
It's approved for various conditions, often superficial or endoscopically accessible cancers, certain types of lung cancer treated via bronchoscope, esophageal cancer, bladder cancer, non-melanoma skin cancers. It requires careful coordination of drug dose, timing, and light delivery.
Fascinating. So pulling back a bit, the most fundamental choice a surgeon makes is still wavelength,
Right.
based on absorption depth and selectivity.
Absolutely fundamental. This connects the physics directly back to the clinical application and the risks. Let's look at the extremes.
Okay, like the CO2 laser, far infrared.
Right, CO2 at 10,600 nanometers, its wavelength is almost perfectly absorbed by water. And since all biological tissue is mostly water,
It gets absorbed immediately.
instantly, right at the surface. The energy is deposited within the first few micrometers, the first few cell layers. This causes that explosive vaporization of the very top layer with very little heat conducting deeper. So the CO2 laser gives an extremely superficial effect. It's excellent for precise surface ablation, like removing skin lesions, or for very fine incisions where you want minimal underlying thermal damage.
What about the other end? UV lasers like excimer.
Even more superficial, UV light is also very strongly absorbed by water and proteins, so its effect is confined to an even thinner layer than CO2. Very high precision for things like corneal reshaping.
Okay, now what about visible light lasers? Ruby, argon, krypton. Their wavelengths are longer than UV, but much shorter than CO2.
Visible light is interesting. Water is relatively transparent to visible light it passes through, but hemoglobin and melanin absorb visible light strongly.
So they penetrate deeper until they hit blood or pigment.
Exactly. They can penetrate maybe 1 to 2 millimeters into tissue before being significantly absorbed. This makes them ideal for targeting vascular lesions like port wine stains or pigmented lesions like moles or tattoos that lie deeper within the dermis. Argon and KTP are workhorses for vascular stuff. Ruby, especially Q-switch, is great for pigments.
And then there's the near-infrared NDDRAG at 964 nanometer.
Yeah.
You said this one penetrates deepest?
By far. Near-infrared light, like the NYAG wavelength, is poorly absorbed by water and poorly absorbed by melanin and hemoglobin compared to visible light. So it passes through the superficial layers relatively easily.
Meaning it travels further before depositing its energy.
Much further. It can penetrate 5 to 7 millimeters into tissue before being significantly attenuated. This is the most profound difference and the one that carries, frankly, the most significant hidden risk.
Why hidden risk?
This is where elite mastery comes in. Because the NYAG beam is invisible, and it doesn't cause much visible change on the surface as it passes through, but it's depositing energy deep inside. And importantly, it scatters significantly as it penetrates. The energy spreads out sideways deep within the tissue, so the actual zone of coagulation and thermal damage created by an NYAG laser is much wider and deeper than the visible aiming beam spot would suggest.
So the damage you see isn't the full picture.
Not even close. This deep scattering effect makes NDYAG fantastic for bulk coagulation, like debulking large tumors from the inside out or treating deep vascular malformations. But it creates a serious risk of delayed thermal injury. Damage might occur deep to the surface, near vital structures, and not become clinically apparent until hours or even days later when tissue necrosis sets in. The surgeon must understand and respect this deep, wide, invisible energy dispersion. It's a stealth weapon. You have to know its true reach.
That's a critical insight. Okay, let's run through some of the major surgical laser types, starting with that complex YAG family you mentioned. They're all crystals.
Yes, solid-state lasers, usually a YAG, yttrium aluminum garnet crystal, doped with a small amount of a rare earth element. Changing the dopant changes the output wavelength.
So the main one is NDD.YAG, neodymium dope.
Correct. NDYAG, emitting at 164 nanometers in near infrared, as we just discussed. Invisible beam needs a visible aiming beam, usually red heme. Deep penetration, significant scattering. Primary roles are deep tissue coagulation and bulk tumor debulking. The big caveat is that risk of delayed, widespread thermal injury. Requires careful control of power and duration.
Okay, then there's HOD-YAG, holmium doped.
HOD-YAG emits at 2070 nanometer, which is in the mid-infrared. Now, this wavelength is strongly absorbed by water, similar to CO2, but not quite as intensely. This gives it a good balance. It cuts and vaporizes tissue effectively because of the water absorption, but it also has some coagulation ability, and it can be transmitted through low water quartz fibers, unlike CO2.
So it's more versatile for endoscopy.
Hugely versatile. It's become the standard for many endoscopic orthopedic procedures, trimming cartilage, smoothing bone and joints, and it's heavily used in urology for fragmenting kidney stones, lithotripsy, and vaporizing prostate tissue, like in whole-up procedures. Good cutting, decent hemostasis, fiber delivery.
And the third, YAG, ear GV doped.
Ear YAG. This one emits at 2940 millimometer. Why is that number significant? It's right at the absolute peak absorption wavelength for water. Water absorbs ear YAG light more strongly than any other wavelength, even CO2.
Meaning extremely superficial effect.
Extremely superficial and extremely precise vaporization. Very little residual thermal damage. Superb precision. But the flip side is, because water absorbs it so intensely, it has very limited penetration and coagulation ability. And also, like CO2, it cannot be transmitted through standard glass fibers due to the high water absorption. It needs either a free beam delivery or specialized, often rigid endoscopes with internal mirrors or special fiber types.
What's ERYAG used for then?
Its precision makes it excellent for cosmetic skin resurfacing, removing wrinkles or scars layer by layer with minimal heat damage. And it's used extensively in dentistry for precisely removing decay or preparing teeth. Precision ablation is its forte.
Okay, that covers the WAGs. What about the visible light lasers you mentioned earlier? Argon, krypton, ruby?
Right. Argon is probably the classic visible laser, emitting blue-green light at 488 and 514 millimeters. As we said, visible light isn't absorbed by water, but is strongly absorbed by hemoglobin and melanin. So argon is primarily used for photocoagulation of vascular structures. Retinal photocoagulation in diabetic retinopathy was a huge early use, or pigmented lesions. Krypton lasers are similar, offering different visible wavelengths, blue, green, yellow, red, also absorbed by pigment and hemoglobin, used for similar ophthalmologic and dermatologic applications, sometimes offering slightly different selectivity. And the ruby laser, the first medical laser, emits deep red light at 694 millimeter, again, absorbed by melanin. It's particularly effective, especially in its Q-switch form, for removing dark tattoos and pigmented lesions.
Then there are the excimer lasers. You said they work differently.
Yes, excimers like argon fluoride at 193 nanometer or krypton fluoride at 248 nanometer are ultraviolet lasers. Their interaction is primarily photochemical, not thermal. The high-energy UV photons directly break molecular bonds in the tissue, a process called photoablation. This allows for extremely precise tissue removal with virtually no heating of the surrounding tissue, unmatched precision, and minimal collateral damage.
Which is why they're used for.
Corneal sculpting in refractive eye surgery. LASIK and PRK rely entirely on the excimer laser's ability to precisely reshape the cornea bond by bond without causing thermal scarring.
And one last category, cold lasers, LLLT.
Right. Low-level laser therapy, sometimes called cold lasers. These are typically low-power diode lasers, often red or near infrared. They operate below the threshold required to cause significant heating or tissue destruction. The idea is that the low-level light penetrates the tissues, sometimes up to a couple of inches, and instead of destroying cells, it stimulates them. Biostimulation. It's thought to enhance cellular metabolism, reduce inflammation, and promote healing.
Is this widely accepted?
It's somewhat controversial, but it is FDA approved for specific applications, mainly temporary relief of minor muscle and joint pain, stiffness, arthritis pain, and specifically for temporary relief of pain associated with carpal tunnel syndrome. It's about stimulating biology, not ablation or coagulation.
Okay. An incredible range of tools, each with specific physics and applications. Which brings us squarely to the most critical imperative: comprehensive laser safety. The power demands respect.
Absolute respect, non-negotiable. Let's start with how lasers are classified, because this dictates the required precautions.
4 classes, right?
Yes, universally classified into 4 groups based on their potential to cause biological damage. Class 1 is inherently safe, like a barcode scanner. Class 2 are low-power visible lasers where the blink reflex offers protection. Class 3 has subtypes, potentially hazardous with optical aids. But the critical point for everyone in a medical setting is that most surgical lasers are Class 4.
And Class 4 means?
It means high power. Output greater than 500 milliwatts in continuous wave mode, or delivering significant energy in pulsed modes. Class 4 lasers are, by definition, hazardous.
Hazardous how?
Profoundly hazardous. They pose a danger to the eye and skin not just from the direct beam, but also from specular reflections. Mirror-like bounces off smooth surfaces and even from diffuse reflections, scattered light bouncing off rough surfaces. Plus, they carry inherent risks of starting fires and often involve high-voltage electrical components. Class 4 status mandates stringent administrative, engineering, and procedural controls. Regulatory bodies like the FDA, OSHA, ANSR, and professional groups like AORON all have guidelines.
You mentioned the eye hazard first. That seems to be the biggest concern. Why is the eye so uniquely vulnerable?
It's the lens. The eye's natural function is to focus light onto the retina. It does this incredibly efficiently. When perfectly collimated laser light enters the eye, the cornea and lens focus it down to a tiny spot on the retina. This focusing action acts like a magnifying glass for power density, amplifying the irradiance, the power per unit area on the retina by up to 100,000 times.
100,000 times amplification.
Yes. Think about that 1 milliwatt laser pointer beam we mentioned. If that hits the retina after being focused by the lens, it's delivering the equivalent of 100 watts per square centimeter, enough to instantly burn, cauterize, and permanently destroy retinal tissue. A momentary exposure can cause irreversible blindness.
And the specific damage depends on the wavelength hitting the eye.
Exactly. Different wavelengths are absorbed by different parts of the eye. We can broadly divide the ocular hazards into 2 main zones.
Okay, zone 1.
Zone 1 is damage to the front of the eye, the cornea and lens. This is primarily caused by wavelengths that are strongly absorbed by water or proteins before they can reach the retina. That includes ultraviolet, UV light, mid to far infrared light, like the HOE-EG and EUR-EG, and especially the far infrared CO2 laser at 10,600 millimeters.
What kind of damage do these cause?
Things like photokeratitis, like a sunburn on the cornea, cataracts, clouding of the lens, and direct corneal burns. Fortunately for invisible lasers like CO2, exposure usually causes immediate intense burning pain on the cornea, which triggers a defensive reaction in an awake person.
Okay, but the second zone sounds more dangerous because it might not cause immediate pain.
Precisely. Zone 2 is retinal damage. This is caused by wavelengths that can pass through the cornea and lens and get focused onto the retina. This is the visible light spectrum, 400-700 millimeter, and the near-infrared spectrum, 700-1400 millimeter.
And that includes the N.YAG laser at 10,064 millimeter.
Critically, yes. The end-wide AG beam at 10^64 nanometer is invisible. It passes straight through the cornea and lens without being felt or seen. It gets focused onto the retina, and here's the terrifying part. The retina itself has no pain receptors.
So you wouldn't know you've been hit.
You would have no idea. Severe thermal burns and, especially with Q-switched pulses, photomechanical shockwave damage can occur instantly and silently. The individual might only realize they've suffered a permanent retinal injury, a blind spot, hours or days later. It's incredibly insidious. Invisible near-IR lasers are arguably the most dangerous from an ocular perspective because the damage is silent and permanent.
This just hammers home the need for proper eye protection. Laser safety eyewear, LSE.
Absolutely mandatory for everyone in the nominal hazard zone during Class 4 laser operation, no exceptions. And, crucially, it's not just any eyewear, it has to be specific.
Specific how?
It must be specifically designed to protect against the particular wavelength or wavelengths being used, and it must provide sufficient protection for the power levels involved. The key metric printed on all certified LSE is the optical density, or OD.
Optical density, what does that number mean?
OD is a logarithmic measure of how much the eyewear material attenuates or blocks the laser light at a specific wavelength. It tells you how much the energy is reduced before it reaches the eye. The goal is to reduce the energy to a level below the official safe limit, the maximum permissible exposure, MPE.
Logarithmic, so a higher OD means much more protection.
Exponentially more. OD1 means it blocks 90%, transmits 10%. OD2 blocks 99%, transmits 1%. OD3 blocks 99.9%, transmits 0.1%. OD4 blocks 99.99%, transmits 110,000. For high-power surgical lasers, you need very high ODs. For example, NDY-AG LSE typically requires an OD of 6 or 7 at 164 millimeters. That means it only allows 1/millionth or 1/10 millionth of the laser energy through. CO2 LSE needs OD7 or higher at 10,600 millimeters.
So you absolutely have to check the LSE markings match the laser being used, wavelength and OD number.
You must. Wearing the wrong LSE or LSE with insufficient OD is the same as wearing no protection at all, and things like generic sunglasses. Useless. They offer effectively zero protection against laser wavelengths.
What about protecting the patient, especially if they're under anesthesia and can't protect themselves?
Patient eye safety is paramount. Their eyes must be securely covered. Usually this involves taping saline-moistened gauze pads over the closed eyelids, sometimes supplemented with opaque external laser shields. And here is a critical life or death warning. Never, ever use petroleum-based eye ointments like Vaseline on or near the eyes during laser surgery.
Why not?
Because petroleum jelly is highly flammable. If a stray laser beam hits that ointment, it can instantly ignite, causing horrific facial burns. Only use water-based lubricants if absolutely necessary and rely primarily on moistened pads and shields. And remember, under general anesthesia or deep sedation, the patient loses their natural blink reflex, that quarter-second aversion response to bright light. They are completely vulnerable to accidental exposure if their eyes aren't properly shielded.
Okay, eye safety is huge.
Okay.
But you mentioned other hazards, non-beam injuries, like the smoke plume, LGACs.
Yes, laser-generated air contaminants, or LGACs, often called the laser plume or smoke. When a laser vaporizes or coagulates tissue, it creates smoke. While about 95% of that plume is just water vapor, that remaining 5% is nasty stuff.
What's in it?
A complex mixture. It contains microscopic particulate matter from the destroyed cells. It can contain viable, live bacteria and viruses, for example. Studies have shown infectious HPV DNA can be aerosolized when treating genital warts. And it contains a cocktail of toxic chemical gases produced by the thermal decomposition of tissue. Things like formaldehyde, hydrogen cyanide, benzene, acetone, a lot of known carcinogens and irritants.
You mentioned earlier the smoke from 1 gram of tissue vaporized by CO2. Is like smoking multiple cigarettes.
Yeah, the chemical load is equivalent to the smoke from 3 to 6 cigarettes, according to some studies. And the CO2 laser, because it vaporizes tissue so readily, tends to produce the largest volume of plume compared to other lasers.
And the particles are small enough to be inhaled deep into the lungs.
Very small. The mean particle size is often around 0.1 to 0.3 microns. That's easily small enough to bypass the natural filtering mechanisms of the upper airway and deposit deep within the alveoli, the tiny air sacs in the lungs. The potential long-term health risks for the surgical team exposed to this day after day include respiratory irritation, potential transmission of infection, and unknown risks from chronic exposure to the chemical mutagens. It's a serious occupational hazard.
So what are the essential mitigation strategies? How do you protect the team?
It requires a multi-layered approach. First, the operating room itself should have good general ventilation. The standard recommendation is a minimum of 20 air exchanges per hour. Second, all personnel in the room should wear appropriate respiratory protection. Standard surgical masks are basically useless against these tiny particles. You need high filtration masks, like a properly fit-tested N95 respirator. But the single most effective measure is local exhaust ventilation, LEV, usually in the form of a dedicated smoke evacuator system.
A vacuum for the smoke.
Essentially, yes, it's a portable unit with a high-efficiency suction pump and a filtering system. The key is that the nozzle of the suction wand must be held very close, ideally within 2 inches, 5 centimeters, of the point where the laser is interacting with the tissue.
Close capture is key.
Absolutely. It needs to capture the plume at the source before it disperses into the room air. And the evacuator itself must use high-quality filters capable of trapping those tiny particles and absorbing the gases. Typically, HEPA, high-efficiency particulate air filters, or even better, ULPA, ultra-low penetration air filters, often combined with activated charcoal for the gases.
Okay, plume control is vital. What about the risk of gas embolism? You mentioned that briefly.
It's rare, but potentially catastrophic. This risk is primarily associated with lasers that use gas, like air or nitrogen or CO2, as a coolant flowing through the delivery system, particularly some older NEYIG systems. If the tip of the laser fiber is damaged, or if gas is inadvertently insufflated into an open blood vessel or into a body cavity being distended with fluid, like during a hysteroscopy,
The gas gets into the bloodstream.
exactly. It can cause a gas embolism, blocking blood flow. This can lead to devastating consequences like coronary artery embolism, heart attack, cerebral artery embolism, stroke, or a large venous air embolism causing cardiovascular collapse. It's particularly a concern during procedures in enclosed spaces like the uterus.
How is this risk mitigated?
Modern systems often use liquid coolants instead of gas, which significantly reduces this specific risk. But awareness, careful technique, and monitoring for signs of embolism remain crucial when using any gas-cooled or gas-insufflating system.
Which brings us to the most dramatic, high-stakes, immediate threat. Surgical fires. You called it a sentinel event.
It is. A fire in the operating room, especially an airway fire, is a catastrophic failure of safety protocols. Statistics show these fires happen most often during surgery on the head, neck, or upper chest. And alarmingly, about a third of all OR fires occur directly in the patient's airway.
Why is the OR such a high-risk environment for fire?
Because all 3 sides of the fire triangle, fuel, oxidizer, and ignition source, are often present simultaneously and in close proximity, especially during head and neck or airway surgery.
Let's break that down. What are the common fuels in the OR?
Oh, they're everywhere. Surgical drapes, sponges, gowns. Alcohol-based skin prep solutions, crucially, these must be allowed to dry completely before draping or using ignition sources, as the vapor is highly flammable. Patient hair can ignite, those petroleum-based ointments we warned against. And critically, in airway surgery, the endotracheal tube, ETT itself, is often the primary fuel. Standard tubes made of PVC, red rubber, or silicone are all combustible, especially in enriched oxygen environments.
Okay, fuel is plentiful. What about the oxidizer?
The main oxidizer is oxygen. Supplemental oxygen is used in the vast majority of surgeries, and it's implicated in something like 95% of OR fires. Nitrous oxide, N2O, often used in anesthesia, also supports combustion just as readily as oxygen. The danger is that oxygen is heavier than air. It doesn't just stay where you deliver it. It tends to pool and accumulate under surgical drapes, particularly around the head and neck, creating an oxygen-enriched atmosphere.
Meaning things burn easier.
Much easier and much more intensely. Materials that might only smolder or melt in room air can suddenly ignite and burn fiercely when the oxygen concentration gets above the normal 21%.
And the third side of the triangle, the ignition source.
In this context, it's the laser beam itself, either the direct beam or an uncontrolled reflection. Electrosurgical units, ESUs, or BUVIs, are actually the most common ignition source overall, but lasers are responsible for about 10% of surgical fires. And unlike an ESU, a laser doesn't need to physically touch the fuel to ignite it if the power density is high enough. Even fiber optic light sources can be ignition sources if placed directly on flammable material.
So fire triangle is complete. Airway fires are the most feared. How do you prevent them? Especially when using a laser in the airway.
Prevention is paramount. The single most important strategy is meticulous management of the oxidizer. The goal is always to use the lowest possible concentration of oxygen that maintains adequate patient saturation. Ideally, keep it below 30% if supplemental O2 is needed near an ignition source.
Oh, well, 30%.
Yes, room air is 21%. Above 30%, the risk of fire increases significantly. If you're using a laser or ESU near the airway during monitored anesthesia care, MAC, where the patient is breathing spontaneously, supplemental oxygen via nasal cannula or mask should be discontinued for at least 1 full minute before activating the laser, and kept off during laser use, if possible. You must allow time for that poured oxygen to dissipate. Continuous suctioning in the back of the throat, or pharynx, is also essential to scavenge any accumulating oxygen and anesthetic gases.
What about the ETT itself, using special tubes?
Absolutely. Standard PVC ETTs are like throwing gasoline on the fire. When using a laser in the airway, you must use a designated laser-resistant ETT.
What makes them resistant?
There are different types. Some are made of flexible stainless steel, like the laser flex tube. Others have a metal core wrapped in special materials, like the laser tubus, which has a Marisol wrap designed to absorb water. Some have dual cuffs. But here's the crucial point. They are laser-resistant, not laser-proof. A sustained direct hit from a powerful laser will eventually penetrate any tube. Their resistance just buys you precious seconds to react.
And the cuff management is non-negotiable.
Completely non-negotiable. The cuff, or cuffs, of the laser-resistant ETT must never be inflated with air. Air just feeds the fire if the cuff is hit. The cuff must be inflated with liquid normal saline. If the laser hits the cuff, the saline absorbs some heat energy and helps extinguish sparks. And critically, that saline must be tinted with methylene blue dye.
Why the dye? You mentioned this earlier.
The dye is the immediate visual alarm system. If the laser beam perforates the cuff, the blue-colored saline immediately leaks out into the surgical field. The surgeon sees the blue dye instantly and knows the cuff has been breached. They stop the laser immediately.
What happens if you don't use dyed saline?
If you just use clear saline, or worse, air, the surgeon might not realize the cuff is ruptured. Oxygen and flammable anesthetic gases could then leak past the damaged cuff right into the path of the laser beam. That guarantees an airway fire. The blue dye is a simple, incredibly effective safety measure.
Okay, prevention failed. A fire ignites in the airway. What happens next? Staff initiate the RACE response for the room.
Right. Rescue patient, alert staff, confine fire, evacuate, extinguish.
But for the anesthetist managing the airway, the response needs to be instantaneous. You said maybe 6 seconds?
It feels like even less. The anesthetist must execute a critical sequence of actions immediately and reflexively. There's no time to think.
What is that sequence? Burn it into our brains.
Okay. Airway fire protocol. 1. Immediately stop the procedure. Discontinue the laser beam A and D. Turn off the flow of all anesthetic gases and oxygen to the breathing circuit. Cut off the oxidizer supply. 2. Simultaneously, remove the source of the fire, disconnect the breathing circuit from the ETT, and rapidly extubate the patient. Pull the burning tube completely out of the airway. 3. If possible, quickly remove any visible burning fragments or debris from the airway or face. 4. Immediately pour saline or water directly into the patient's airway. Flood the pharynx and larynx to extinguish any residual smoldering material and cool the burned tissues.
Stop gas, pull tube, remove debris, pour saline. That's the immediate sequence.
That's the core sequence. 4 steps in seconds.
What happens after the fire is out?
You have to resume ventilation immediately to support the patient, but critically, you must ventilate initially with room air only, or the lowest possible oxygen concentration needed for saturation. Do not use 100% oxygen, as that could cause any remaining embers to reignite. Only increase oxygen once you are absolutely certain all fire risk is gone.
And the follow-up care.
Immediate post-fire care is crucial for long-term outcome. The patient requires an urgent, rigid bronchoscopy. This is essential to visualize the entire airway, remove any residual ETT debris, which can be toxic, and accurately assess the extent and depth of the thermal injury. Reintubation is usually necessary, often with a smaller ETT due to swelling. The patient needs intensive monitoring, typically in an ICU setting, for at least 24 hours, watching closely for delayed airway edema, respiratory distress, or pulmonary complications from smoke inhalation. Steroids might be considered. And long-term follow-up is vital because thermal injury to the airway carries a high risk of developing tracheal stenosis, scarring, and narrowing of the windpipe weeks or months later. Mastery of laser safety absolutely requires internalizing that 6-second fire response and understanding the critical post-fire management.
Wow. Okay, this has been an incredibly rigorous deep dive. It really demonstrates that the medical laser is this amazing, powerful fusion. It's high-level quantum physics harnessing stimulated, coherent light combined with meticulous, almost ritualistic, procedural safety needed to manage Class 4 power tools in a clinical setting.
Absolutely. The path to what you called elite mastery really hinges on integrating all these levels, understanding the physics of wavelength specificity to target the right chromophore, knowing the biology of tissue interaction and TRT, and then applying the engineering and procedural knowledge using the correct optical density LSE for the specific wavelength, managing the plume, and having absolute reflexive internalization of those fire protocols, knowing fuel, oxidizer, ignition, and the response.
We've seen that the incredible energy contained in that tiny focused laser beam, potentially 1,000,000 times more concentrated than an ordinary light bulb, is quite literally the difference between life-saving precise surgery and a catastrophic never-event sentinel event.
It truly is. And this leaves us with a final thought for you, the listener, aiming for that mastery to really consider. We know the profound risks associated with this technology. We've discussed ocular hazards, the documented dangers of LGACs, the potential for fires. Yet some aspects, like plume management, rely heavily on voluntary compliance and professional standards, as regulatory enforcement by bodies like OSHA or ANSI isn't always perfectly consistent or rigorous across all facilities. So the question becomes, given these known risks, what level of voluntary commitment to safety must you commit to that goes beyond merely following the minimal written guidelines? When dealing with power this intense, is simple adherence to minimum standard truly sufficient? Or must elite professionals cultivate and demand a continuous standard of absolute vigilance, exceeding the baseline requirements to truly protect themselves, their colleagues, and their patients? Think about that level of commitment every time you step into a laser procedure room or review these safety protocols.